Hello, my name is Ivy Chang. I'm a sports medicine physician at the Sports Medicine Specialists and also an emergency physician at Sunnybrook Health Sciences Center. Thank you very much for inviting me to teach you about altitude-related illnesses. I have a special interest in mountaineering medicine and had the privilege of being a base camp physician on the north side of Everest. So we're going to learn around some cases today, and the objectives is to discuss altitude-related illnesses, of which there are three. So we are going to talk about acute mountain sickness in terms of the diagnosis and the prevention, risk, and treatment, as well as high-altitude cerebral edema, or HACE, and high-altitude pulmonary edema, or HAPE. And we're going to learn this through by going through a few cases, and let's get started. So we're going to say that you've been invited as the base camp physician to go do help out a team who wants to climb the north side of Everest. You meet your team in Kathmandu, which is at sea level, and you travel by plane and arrive at Lhasa in Tibet at 3,600 meters. And then by jeep, you and your team travel to Shigar, Tibet, which is at 4,300 meters, and you rest there for 2 days, and you had rested in Lhasa for 3 days. And then afterwards, there is a drive up to the north side of Everest Base Camp, which is at 5,300 meters, where the team is going to rest there for 4 days. And upon arrival, you do notice that one of your team members is not feeling very well. And she complains that she has a mild headache, not feeling dizzy, had a hard time sleeping the night before, feels nauseous, doesn't really feel like eating any form of solids, and has noticed that the urine has been a bit darker and not as frequent. On the physical exam, you bring out your medical kit, you notice that there's no fever, but there's a mild tachycardia of 105, blood pressure is reasonable at 140/60, saturations are low at 61%, but despite that, she is very clear. She's a little bit pale, but the chest has no accessory sounds, and you're able to ambulate from the tent from one side to the other, and there is no ataxia. She does, you do notice from a picture from before and after that there is some facial swelling now. And so for the major differential that you'll have will be acute mountain sickness. Saying that, though, there is a large differential, and you need to keep this in mind because AMS is very similar to any form of flu or viral illness. Because there's a headache component, there can be anything related to headaches such as migraine headaches, or even up to adrenal venous thrombosis, because that could present simply as a headache and not necessarily any other neurological deficit. Sometimes toxins can actually be involved, such as carbon monoxide poisoning or getting intoxicated the night before, so the history is kind of important, or a person going through alcohol withdrawal can also cause these type of symptoms. However, given the altitude change, the main differential would be altitude illness, but you could also consider high altitude cerebral edema. Saying this, though, in the next few slides, we'll talk about why it's not the case. There is a very useful tool for using your clinical signs and symptoms to talk about the severity of acute mountain sickness, and this is the Lake Louise score. And here is a chart that can help you. And the diagnosis of acute mountain sickness is based on a rise in altitude within 4 days, which has happened to our colleague with the presence of a headache. And then using other scores based on the headache, the GI symptoms, which are inclusive of the anorexia, the vomiting, fatigue or weakness in terms of how tired they are, if they're dizzy, and also their inability to sleep. And if they have a score more than 6, or more than equal to 6, then this is severe AMS. So scoring Our Lady, there is a headache. There was a little bit of nausea. She feels a little bit tired, not dizzy, had a little bit problem sleeping, but not horrible. And then with respect, there was absolutely no ataxia. There is some facial swelling, and essentially the AMS score is 6, which is actually in the severe realm. But why not HACE? So HACE in this individual would not be within the diagnosis, and that's good news because she was not confused, she was not ataxic, and she was not comatose. Be aware that with the higher technological expeditions now, some physicians actually bring a bedside or portable ultrasound, and nowadays acute mountain sickness can be speculated to be diagnosed by looking for an increased diameter of the optic sheath. However, I think that the Lake Louise score would be more than adequate to help you diagnose AMS. So what is the risk of acute mountain sickness? It is rare below 2,500 meters. So once this whole team flew into Lhasa, Tibet, they were actually at risk for acute mountain sickness because they were higher and above 3,000 meters, and there was a relatively rapid ascent despite the fact that there were a lot of rest days. And the Centers for Disease, and what you do need to know is that actually in North America, there are actually places that have risk, especially some of the ski resorts down in the United States. So the mountains in Utah, Colorado, Arizona, New Mexico, and Wyoming all have mountains that are higher than 2,500 meters. There are mountaineers that do go climb in North America. The highest mountain in Canada is Mount Logan, which is at 5,900 meters, and there's Denali in the United States, which is 6,190 meters. So to actually prevent getting mountain sickness, the major prevention is the ascent profile. So if you want a very conservative profile, would be a slow ascent of 300 meters a day only, and a rest day after 900 meters. In the Centers for Disease Control, which we're going to talk about in the next few slides, they recommend 500 meters a day and a rest day after 1,000 meters. And be aware that most trekking agencies don't follow this because that is a pretty slow ascent profile. High carbohydrate diets have been speculated to be preventative, and you can also take acetazolamide. So the reason behind getting altitude-related illnesses is from the hypoxia and the decrease in pressure. So as you go up, the oxygen partial pressure decreases quite significantly, especially when you're at 8,000 meters. And what actually happens is that the body needs to acclimatize. But because of the hypoxia, we start to hyperventilate and we get a respiratory alkalosis. And then the water balance in our body seems to become a bit disrupted. The physiologists are still trying to sort out exactly why, but it seems that we tend to get pulmonary hypertension in our lungs, but then we get leaky capillaries in the lungs, and we get these fluid shifts that can actually cause some brain swelling. So for acute mountain sickness, it is just on the spectrum between that and high altitude cerebral edema, and so what happens is that the headache is a sign that the brain has gotten a bit more swollen. So medications that can kind of help for altitude illnesses is to help acidify the blood and to get rid of the extra alkalosis that's caused by the respiratory alkalosis. So acetazolamide can be helpful, and doses can be from 125 to 250 twice a day. It is a diuretic, so it makes you secrete out the fluids as well as the bicarbonate. But it does have some side effects because it can give you peripheral numbness and tingling. It can also make carbonated drinks taste awful as well, and it also makes you urinate a lot. But it has been known to help prevent the symptoms of AMS, or at least treat them, and also help sleep. And of course, being hypoxic, the better treatment as well as you can get oxygen, or just to descend down to a level where the partial pressure of oxygen then normalizes. For sleep, it is important to avoid sedatives such as benzodiazepines because you'll just become more hypoxic when you take it. However, there are medications such as zolpidem that do not cause you to hyperventilate, and they should be okay for insomnia. The other non-medical or non-medicine way to actually prevent getting an altitude-related illness is to have mild or moderate exercise while you're ascending. Of course, this is very difficult because ascending is exercise, but trying not to overexert yourself when you're actually going up the mountain. Proper hydration with proper electrolytes is also very important to prevent dehydration. So up to maybe 4 to 6 liters per day, depending on your body weight. And as you go higher, you do dehydrate much more, and you need to rebalance with the appropriate fluids. There's also to avoid alcohol for 48 hours, and to be very aware that the level of fitness is not predictive that whether or not you're going to get these altitude-related illnesses. So you can be extremely fit, but still actually get AMS, HACE, or HAPE. The next couple slides are a little bit busy, but they're very good references for you to use if you have a client that is asking you how to prepare and whether or not they should get prophylaxis if they're going to altitude. And you can see, so this is from the Centers for Disease Control, and you will see the low, moderate, and high risk of getting acute mountain sickness, and whether or not acetaminophen prophylaxis is recommended. So it's based on the Ascent profile and whether or not you've had any form of altitude-related illnesses in the past. So if you've had altitude-related illnesses in the past, then prophylaxis will start at a much earlier level, such as down at even 2,500 meters if you've had AMS before. But if you've never had AMS before, then prophylaxis may not start until you get up to about 3,000 meters or higher. The next slide is also from the Centers for Disease Control, and I've also provided you the link to access it. And these are for patients with pre-existing conditions. And essentially, any individual who has severe lung, cardiac, or brain disease should probably not go to altitude. And when we talk about severity, it would be like severe heart failure with a very poor left ventricular function, or very poor lung exchange like severe COPD, or pulmonary hypertension. If they have any type of brain tumor, aneurysm, it's not recommended that they go to altitude. However, no extra risk is required for individuals. We often think of children. They should be okay as long as they're not babies and less than 6 months. But elderly people and people with mild obesity can still actually go up to altitude as long as their ascent profile is reasonable. So we have our lady, we're going to go back to lady, and with her 6 out of 24 symptoms of AMS. And the main treatment for her is to not ascend any further. If you wanted to be much more conservative and safe, she could descend. But as long as she would not ascend until her symptoms resolved, and then she can probably continue her trek. If she really wants to get a lot of her symptoms gone, then even a descent of 300 meters would be fine. So a lot of the trekking agencies, the rule is to ascend, but you can go high, but you sleep low. So you can actually go up to, say, 3,000 meters, but when you're going to go and rest, you actually descend back down to 2,700 or 2,500 meters and you sleep low, and that's actually a very good acclimatization profile. If you descend at least a kilometer, most all of the symptoms will disappear. As well, to maintain adequate hydration, this lady could also get a dosage of some Diamox, even 250 milligrams or 125 milligrams. And then if there is supplementary oxygen, which many of these tours often have, this could also be given just to help bridge her over. There is the possibility of using a hyperbaric chamber. This should not be the mainstay treatment. The hyperbaric chamber is usually a stopgap measure to allow the person to be able to self-rescue, which means that they just descend on their own. But what actually happens is a simulated descent. The person sits in the bag. It is a foot pump that actually puts up the pressure actually in the bag. Oxygen is actually put in with the patient, and they get a simulated descent. But it is actually a very work-intensive way to get the person better. And so the better option is to actually have the person just descend on their own. And as well, you can use dexamethasone as a treatment, but it should not really be used for prophylaxis, despite the fact that some people have been using it. But dexamethasone is a drug that should be used with caution because it has so many side effects with the adrenal as well as psychotic side effects. The dose is 4 to 8 milligrams, and it should not be given for more than 3 days. So that is acute mountain sickness. And let's revisit our same lady, and we're going to give a different ascent profile. So she has decided that she is going to go to Kachichenjunga Base Camp. And so the ascent history is on the second day. She is able to get up to 2,300 meters. And then within 2 days, goes up to the north side of Kachichenjunga Base Camp, which is at 5,388 meters. She again is not feeling, or he again is not feeling very well, has a headache this time, is now dizzy, had not slept yesterday, it has vomited twice, but is now confused, it's not giving good a story, and it's also anorexic. When you examine him, you do notice that there is much more facial swelling. He can't walk great, there is ataxia, noticed again the confusion, and clinically this now is on the spectrum of altitude-related illnesses. It has now progressed to high-altitude cerebral edema. And essentially it is just as the name says. The capillaries have become so leaky, the fluid has shifted, and now the brain has become swollen. If you are able to ever MRI this brain, there actually is some swelling at the splenium of the corpus callosum, and here's a picture of the MRI. The risk of actually getting HACE is when you're greater than 4,000 meters. So once he had reached Kachichenjunga Base Camp, risk was actually higher. And the treatment for high-altitude cerebral edema is urgent. The mainstay is to descend by any means possible. So put him on a yak, walk him down, put him on the shoulders of a climber who can bring him down, but this use a helicopter descent, but the patient must descend. And that is because it can be a life-threatening illness, especially if they're comatose and confused. As well, for the treatment, there's often supplementary oxygen. So this is the Poisk bottle that is actually used for Everest summiteers. The pack or gamma bag can be used as a stopgap measure and life-saving to get them such that they can actually rouse enough such that they can self-rescue. And the dexamethasone should be given emergently, which is 8 milligrams IV or PO, and then 4 milligrams 4 times a day. Okay, so the next case. So what actually happens is we are going to keep on going back to the Everest side, and from base camp, we go up to advanced base camp. So from 5,300 meters, there's a 3-day trek, and the team goes up to 6,400 meters, and your colleague decides that they want to go up to North Col, which is up to 7,100 meters, and starts climbing up there. Now they're up to 4 days at altitude, and en route to North Col, she started to have a cough. And everybody gets a cough when they're actually in the Himalayas. They call it the Kumu cough. But you do notice, and you take a temperature, not too much of a fever, but notice that the fingers are cyanosed. The sats again are down to 75, 71%. There is definitely a sinus tachycardia going on when you listen. It's irregular. We don't have an EKG machine, but you assume that it's a nice regular beating pulse. And you take out your stethoscope, and you listen, and you can hear rouse and extra sounds, and the rest rate is increased. It's now 24 breaths per minute. If we had our chest x-ray machine there, or if you have portable ultrasound, you can see with the chest x-ray there would be more congestion in the lungs with a normal heart size, looking like pulmonary edema. And with the ultrasound, which would be lovely to have at base camp, we can see B lines, and this is on the right-hand side of the slide that shows that there's actually fluid in the lungs. This is high-altitude pulmonary edema, and the risk is actually at about 4,500 meters and higher, and especially if there's been a prior history of high-altitude pulmonary edema. It is the most common reason for dying from high-altitude related illnesses. There is also something called re-entry HAPE. So if you are going to be doing any form of work in the Nepali or Himalaya area for the local people, individuals who do live actually at high altitudes, say they live at a village that's at 3,000, 4,000 meters, and they go down to Kathmandu and they go back up, they can get something called reentry HAPE. One of the biggest red flags for altitude pulmonary edema is somebody who says they're short of breath at rest and just feels really bagged and tired and just can't seem to get their air. If they're coughing up blood, it's quite serious, and HAPE can progress to cerebral edema if untreated, especially because of the hypoxia. And everything begins to snowball because what happens is you get hypoxia, and then you actually get congestion of lungs. And because you're actually at altitude and with the ultraviolet radiation and the hypoxia, the body becomes relatively immunosuppressed. So the risk of infection of the lungs is actually higher. So for treatment for HAPE, if it's mild, so SATs are good. So say the SATs were like 89%. They're not having any nighttime shortness of breath. They're only getting some shortness of breath at exertion, maybe an intermittent crackle here and there. So just no ascent. Make sure that they rest, no overexertion, wait for their SATs to come up, their heart rate to come down, their tachypnea to resolve, and perhaps they can continue to climb. However, if the patient actually has audible rouse, shortness of breath at rest, really quite exhausted, quite severe in terms of their HAPE, then they probably should be they definitely need to be evacuated and descent. So the treatment immediately is to give them supplementary oxygen. You can use Ceravent. You can also decrease their pulmonary hypertension by using extended release nifedipine, 30 milligrams twice a day, or you can use a phosphodiesterase inhibitor such as tadalafil, which is 10 milligrams twice a day. And descend. That is the trick. If they are unable to walk, then you can use the hyperbaric chamber until they can actually self-rescue, or actually help them descend by getting a helicopter slash yak slash personnel rescue to help them descend. So to prevent patients or trekkers or colleagues who've had prior HAPE, definitely the ascent profile has to be moderated. So if they had prior HAPE before, they probably should ascend much, much slower. They definitely should have no ascent if they're symptomatic, or just descent. There needs to be minimal exertion for 2 days after reaching 2,500 meters. And prophylactically, they can use the calcium channel blocker, phosphodiesterase inhibitor, a bronchodilator, and acetazolamide to prevent it. And again, from the Centers for Disease Control, I'm going to provide you a nice summary table in terms of some medication dosages to prevent altitude illnesses for AMS, HACE, and HAPE, and it also provides adult and pediatric dosages. And the link to the Centers for Disease Control website is attached. So I also wanted to emphasize the dangers of prophylactic dexamethasone. So there's a great article from Outside Magazine about it that you can access online. And it was a case of an individual who was prescribed about 90 vials or 90 tablets of dexamethasone plus a bunch of vials to help him summit Everest. And this individual took 86 tablets of dexamethasone by the time the physicians at the base camp had found him. And by that time, he was psychotic with adrenal shutdown and actually developed an upper GI bleed. He has suffered from some long-term effects and with still tremors even at this time. So be very careful by providing dexamethasone to your patients, and it has to be provided by the very strict guidelines in terms of what to use, and it should not be used as a prophylactic. So thank you very much for listening, and as promised, there are some questions for you for review. In terms of references that were used, use the Center for Disease Control website, as well in the emergency medicine textbook by Rosens. There is actually a whole section on altitude-related illnesses, and there's also the textbook of wilderness and environmental medicine by Auerbach that will also go over a lot of the basics of altitude-related illnesses. In your sports medicine text, There, by Bruckner and Kahn, there is a section for athletes at altitude, and we can also provide you a supplementary article from the Journal of Sports Medicine on guidelines for athletes at altitude. And you can go through your questions. So there's question 1, 2, 3, 4, and 5. And then there are the answers at the bottom of the slides. Thank you very much for listening, and have a great day.